Hi, welcome to U.S. Healthcare Systems, HEMBA 5455, and I recorded this presentation just to supplement the material that's in your text, the She and Sing book, which does a really great job in giving an overview of all the elements of our current healthcare system and what's happened over the past several years to shape it. She and Sing have 10 characteristics or components of our healthcare delivery system in the U.S., and they're really great. And I've repeated a few of them here and sort of added my own and put my own slant on this. First of all, there's a real division between the public health system, which keeps people healthy in the U.S., and we're going to talk about that in more detail in another couple of weeks, and the medical care system, which takes care of them when they're not. And as you know, there's not always communication between the two of those, except for perhaps in an organization like Group Health or Kaiser Permanente. There's also a great deal of emphasis across the U.S. healthcare system in institutions like hospitals, so in brick and mortar and stuff. And I think partially that's because Americans love new shiny things that reflect quality, or at least what they think reflects quality. But I think historically it goes back much further than that to the 1953 Hill-Burton Act, which was put forth by President Truman and was really designed to provide federal grants and loans to improve the physical plan of the nation's hospital system. At that time, we really equated quality of care with the facilities that were present to provide it. And so the overarching goal of that Hill-Burton Act was to achieve about 4.5 beds per 1,000 people. And it's interesting to think about how now we do equate access to hospital beds on one level, but overall, that's just one piece of access to health care. Of course, we don't strive to have quite so many hospital beds per capita now. It's not necessary. We have other services on the continuum of care that are equally as important. And then, of course, access to care is limited in the U.S. We don't have universal access. Even with the ACA, we are still lacking in access to care. So those are a few of the characteristics, and I've got more on the next slide. Continuing with defining characteristics of our U.S. Healthcare system, I think we need to include medical technology, as that really defines U.S. approach to healthcare more so than most Western nations, and that we put a lot of emphasis and value on that. And it not only fuels expansion, but drives costs. And certainly if I was to need some kind of high-tech procedure, the U.S. is where I would want to be. There are many other countries where I wouldn't mind having that done as well. Heart procedures, neuro, whatever, but that is something that we do very, very well. The trouble is, we do that well to the detriment of other parts of the services that we need to provide. And I don't have to tell you all in terms of prevention, and duplication. Everybody has to have a new MRI machine. We can't specialize in one campus or one competitor versus another. Everybody has to have one. So as Don Berwick says, we do rescue care and high-tech care very, very well, but in other areas, not so well. We definitely have a somewhat dysfunctional financing and payment system, and it's fragmented and different depending on the payer and so forth. And we'll be talking about that more later. There's tension between the free market and government control, and we don't have a free market when it comes to healthcare. And I think this is very surprising for most consumers that we don't have that free market competitive edge that defines capitalism, and we're going to talk about that in a little more in a minute using Michael Porter's work. And many systems make up the overall system, and they don't all communicate with each other, as you know. There are many issues and concerns with the U.S. healthcare system, and I probably sound rather negative because I'm not putting all the positives down here, but I think the issues in many ways outweigh the benefits. And this is just to name a few. Quality, we equate quality, as I said before, with technology, and when we look at overall population outcomes, they're not so good. That we need to improve access and coverage. Even with the Affordable Care Act, we have many people that still lack coverage and access to basic health care. We need to slow the growth of health care costs. We need to encourage healthy behaviors, and that's slowly changing with the Affordable Care Act, putting more emphasis on prevention care, but we still have a ways to go. Our public health care system is very fractured right now and needs to be improved. And we need to improve coordination, transparency, and accountability across healthcare systems. So this is going to be fun as we discuss all of these issues this quarter and provide perhaps some of the answers. There's basically four main models of delivering health care, and you saw examples of each of these in the T.R. Reid video, which I hope you enjoyed. There's the Beveridge model. I'm not sure if I'm saying that correct, but it's a universal coverage model, which was established in 1946, and it's funded primarily through taxes. And you can find that model in Great Britain, Spain, and New Zealand. And of course, it's not a perfect model, but the people who are in it, I think by and large, find it's great because they're not paying for it out of pocket. They are paying for it through taxes, of course. The Bismarck model was originally called the sickness funds, in that it was financed originally through employers and employee contributions, sort of matched contributions. And we have that model in the U.S. now, where the employer puts in some of your premium and then we put in the rest to cover our family and so forth. But when it was conceived, it was a very economical model. And unlike the U.S. insurance industry, the Bismarck type healthcare insurance plans don't make a profit. And so I think that's one very big difference between that model and the U.S. model. And it's a universal model in Germany, for example. What's really interesting is in about 1915 or so, 16, a group of representatives from both labor and industry went to Germany to look at that model and came back with a report that we ought to do this as a national health care plan, and we ought to use the Bismarck approach in the U.S., and actually went to Congress. But very close on the heels of that visit, maybe a year or two later, World War I started, and so people were very, very suspicious of anything that came out of Germany, and plans were completely scrapped to adopt the Bismarck model. But we came sort of close, not real close, but did consider it. The third type of model is the National Health Insurance model, which sort of is a combination of the Beveridge and Bismarck models, in that it uses private sector providers, but the payment comes from a government-run insurance program that all citizens fund through their taxes. And that system can be found in Canada. And there's kind of a hybrid of that in the Scandinavian countries, in that you see both a number of government-run programs, but also some private. But it's overseen by the government. And then, of course, there's the out-of-pocket model, which is found throughout most of the third world or undeveloped countries, and somewhat in the U.S. In the U.S., you will actually find all four of these models. I wanted to include a little bit of Washington State history and healthcare reform here, because if you weren't living here in the early 90s, you probably are not aware that in 1993, we adopted a very extensive healthcare reform, and it was really the first ever enacted by a state in the U.S. If you might recall, at that time, Clinton was in office. Hillary Clinton was leading healthcare reform. There was a lot of momentum across the U.S., and we had a very liberal, kind of innovative governor at the time, Mike Lowry. And so we passed a reform that would have waiting periods for pre-existing conditions abolished. Insurers were required to sell policies to anyone who could pay. Individuals were required to purchase coverage. And you might recall that this is one of the cornerstones of the Affordable Care Act, and it's controversial. However, if you think about how car insurance works, the reason our car insurance policies are actually affordable is because we have a wide pool of people who are paying into that premium pool. So with healthcare insurance, you want everybody paying into that pool, including the healthy people who are not using a huge number of the services, to balance out the high users. And so Washington State was kind of ahead of the wave on that one. And then employers were required to offer insurance to employees. So some of the pieces of the Affordable Care Act were passed by Washington in 1993. So what happened to that law that was passed? Well, it was a train wreck. It was very sad. It didn't take long for this to just completely go down the tubes. We didn't receive a federal waiver from the provisions of ERISA. Was the really the biggest part of this, and most large self-insured employers were not included under the reform plan because those companies' health benefits were governed by the Employment Retirement Income Security Act of 1974, and that's a federal law that sets minimum standards for most voluntarily established pension and healthcare plans in private industry. And so so that really decreased the pool. The pool of people who sought individual plans then was very skewed and were really the higher risk individuals. And so, as I was just saying in the previous slide, when you don't have those low risk healthy people in the pool, it really drives costs up. And then the newly elected legislators just repealed it. And then, of course, Lowry had some problems and was not reelected for a second term. So that was sad. At any rate, it's interesting, and I've attached within the modules a analysis of this case that was done by a professor at the University of Washington, I believe. It's a PDF file that's within the modules. If you're interested in reading more about this very interesting piece of our history that was very short-lived. Since the United States is very much a free market, capitalistic kind of country when it comes to business, I think it's interesting to look at Porter and Teesberg's work on looking at why competition hasn't worked in healthcare. And Porter and Teesberg feel like if we change some things, it actually could work very well. Their book on redefining healthcare, which I think came out in 2004, is really excellent if you haven't seen it. And they've also written some articles. I didn't assign one, but if you're interested, it's very easy to find. And I'm more than willing to loan you my book. When we look at competition, what are the reasons